Welcome to Intellect Medical ZM. Today we're going to talk about blood pressure. So our objectives in this tutorial are to define what blood pressure is, factors that influence blood pressure, mechanisms that regulate blood pressure. So by definition, a blood pressure simply refers to that pressure that blood exerts on the walls of the blood vessels or the endothelial walls of the blood vessels, regardless of its quantitative measure. Yeah, so this is important to understand. When you hear blood pressure, automatically, oftentimes, people get to associate it with hypertension, but that is not true. And oftentimes, you hear people referring to a client who has hypertension saying this client has BP. But when you say BP, which one? And that's what one has to understand from this definition, that BP does not specify which one you're talking about. Yeah, so there are three subvariants of this blood pressure or BP. So the BP can either be normal or normal tension. The BP can either be high or hypertension. The BP can either be low, which is also known as hypotension. Yeah, so it's also important to understand the values. Yeah, always familiarize yourself with the normal before you get to judge what's abnormal and how to go about it. Yeah, so always understand those ranges of the optimal less than 120 millimeters of mercury systolic and less than 80 millimeters of mercury diastolic. Yeah, you can even it will do no harm to understand also what is referred to as that normal and the high normal, where you can talk of ranges of 120 to 129 and 80 to 84 diastolic. Yeah, so such ranges. Yeah, and to what extent do we get to regard this as hypertension, of which we did in our previous lecture? So remember, levels above 140 millimeters of mercury systolic and above 90 millimeters of mercury diastolic will enter into that category of what is referred to as hypertension. And for hypotension, we have usually levels of less than 90 millimeters of mercury systolic and less than 60 millimeters of mercury diastolic, and with some clinical features that signifies hypotension or suffice in terms of coming up with that clinical picture of hypotension. So actually, before I talk about factors that influence blood pressure, one thing that I would want everyone to have in mind is that whenever you hear blood pressure, the first thing that should come into your mind is cardiac output and peripheral vascular resistance, because these are the things that define blood pressure. Yeah, so what I simply mean here is that whatever happens to whatever changes happen to cardiac output will affect blood pressure in a way. It's either it will go up or down. Whatever changes happen to peripheral vascular resistance will also affect blood pressure in a way that it may go up or down. So let's say cardiac output increases. If anything increases cardiac output, blood pressure increases. If anything increases peripheral vascular resistance, blood pressure increases. And the opposite is also true for hypotension. Yeah. So um, uh, it is important to understand these factors, because oftentimes things that influence blood pressure will play along these main factors, which is cardiac output and peripheral vascular resistance. Okay, so factors that influence blood pressure are mainly five. We have cardiac output, systemic vascular resistance, blood volume, viscosity of blood, and elasticity of the blood vessels. So now let's quickly, briefly talk about these factors and how they might influence blood pressure, or how they might affect blood pressure. Yeah, so we talk about cardiac output. So just like I said earlier, cardiac output is one of the main factors that the affects BP, or rather defines BP. And oftentimes, because of the minimal contribution that these other factors have towards blood pressure, mainly you find that cardiac output and systemic vascular resistance are the main factors that will be talked about. And blood volume, or obviously some extent, to define, or rather talk about effects of these factors on blood pressure. Yeah. So we talk about cardiac output now. So cardiac output refers to the volume of blood pumped out of the heart in a minute, yeah, and it is determined by two main factors, which is stroke volume and heart rate. So this stroke volume refers to the volume of blood that is pumped out of the heart per beat, yeah, and heart rate simply refers to the number of times that the heart gets to beat in a minute, yeah. So at the end of the day, whatever happens to stroke volume or heart rate will affect cardiac output, and when cardiac output is affected, blood pressure is also affected. So let's say, before I give a general picture on how this effect may come about, I just want to talk about things that might also affect stroke volume. Yeah, so there are also other factors that might affect stroke volume and the heart rate. So there are three main factors that can affect stroke volume, and these are end diastolic volume, the contractility of the heart muscle, as well as afterload. So end diastolic volume simply refers to that volume within that volume of blood in the ventricles prior to contraction, before the heart contracts. So this also refers to preload, that amount of stretch of the ventricles during that ventricular filling, because it is actually that amount that will determine how much of it goes out. If there's less amount of volume during ventricular filling, obviously you expect less to come out, and that decreases stroke volume, which also decreases cardiac output and might decrease blood pressure. So you see that picture there. So contractility also is important, because that force of contraction determines how much amount of blood is going to be ejected during that systolic contraction. Yeah. And afterload also comes in the sense that the volume of blood, or how adequate the heart gets to pump out blood, it can also be affected with the pressure within the arterioles. Yeah. So if there's increase in pressure within the arterioles, it means that the heart has to actually work hard to pump out blood out of the heart against that pressure which is within the arterioles, which they refer to as afterload. So when it's increased, it means that the heart has to work harder to pump out blood. So that can also affect stroke volume, and it might decrease. Yeah. So let's say heart rate. Of course, we have things that can increase the contractility of the heart, things such as increase the sympathetic stimulation, catecholamine production, the presence of calcium, yeah, so increase calcium, as well as the thyroid hormone, which will increase metabolism, which also has an indirect stimulation on heart rate, and these other biochemical processes within the body due to that increased metabolism, where now there's increased demand for nutrients, tissue perfusion, and oxygenation as a result of those metabolic processes taking place. Yeah. So such factors can also affect cardiac output, either by increasing the heart rate and increasing the frequency at which blood is being pumped out per contraction, which also ends up increasing cardiac output at the end of the day. Yeah. So with systemic vascular resistance, what this one simply talks about is that compliance of the vasculature, yeah, to either dilate or constrict in order to maintain blood pressure within the normal homeostatic levels. Yeah. So this one can affect blood pressure in the sense that when blood vessels have increased vascular resistance, where they do not dilate, and there's increased blood volume, that would actually increase the pressure and results into high blood pressure, because there's increased resistance of the blood vessels, they are not expanding, and there's increase in blood volume, so that just ends up increasing blood pressure. And the opposite can also happen in the sense whereby there is increase, there's dilatation contraction of the blood vessels and a decreased blood volume. So if blood vessels do not constrict to maintain the pressure, as a result of that decreased volume, again you end up having low blood pressure in that sense. So when you hear systemic vascular resistance, think of vasoconstriction, vasodilatation. Yeah. So blood volume, of course, blood volume has some sort of direct proportion or effect on on blood pressure. So what I'm trying to say is, when blood volume goes up, blood pressure goes up. When blood volume goes down, blood pressure goes down. Yeah, because blood volume actually plays a major role in terms of maintaining blood pressure. And whenever a client or patient is in shock, one of the main things that we want to maintain is IV fluid administration, so that we can try to push that pressure up. So let's say blood volume goes down. When blood volume goes down, venous return decreases. When venous return decreases, ventricular filling also decreases. So when ventricular filling decreases, remember the Frank-Stallings mechanism, where the force of contraction is actually determined by the amount of stretch of the heart muscle. A good example I can give is of a spring. When you compress a spring, yeah, the way it will recoil when you release it will be the force at which it will recoil when you release it is actually proportional to that force you applied when compressing it. So the more you compress it, when you release it, it will recoil with that great force. So it's a similar concept in Frank-Starling mechanism, where if during ventricular filling, more blood volume pours in, and there's that ventricular stretch of the cardiac muscle. Yeah, it will also contract with great force and eject more blood during that systolic phase. Yeah. So so that picture also is important on blood volume. And when blood volume increases, the opposite again is true. There will be increased venous return, increased ventricular filling with increased amount of ventricular stretching, thereby increasing the force of contraction, and stroke volume also increases, which will end up boosting cardiac output and increasing blood pressure. Yeah. So viscosity of blood, well, this one simply refers to the thickness of blood. Yeah. So when blood is thicker, it actually has that great resistance to flow. Yeah. So with that great resistance, actually just brings in this increased blood pressure as a result of the same increased resistance. Yeah. So elasticity of blood vessels. This one simply talks about the ability of these blood vessels to recoil, like to remodel themselves, to return to that normal structure, that normal shape and structure when there was some conformational changes that took place. Let's say when a blood vessel dilates, it's supposed to return to its normal size. If it constricts, it's supposed to recoil back again to its normal diameter or lumen. Yes. So in cases where let's say a blood vessel constricts and does not recoil due to lack of that proper elasticity, maybe due to damage to the fibers that help to maintain that elasticity. Yeah. So once it constricts and it remains that way, when blood volume increases, there will be greater resistance to flow, which will increase blood pressure. You see that one. So always when you think of these factors that influence blood pressure, think of what are they doing. Are they causing an increase in volume, which will also increase pressure? Yeah. Or are they causing a decrease in the container in which this volume will be contained? Yeah. Of which, when the container is reduced in size, and the blood volume is maintained, there will come a point where blood volume will appear to increase, but in the actual sense, it's the container which has increased and the pressure builds up like that. I would like to paint, a scenario as I've come to the conclusion of these factors that influence blood pressure. So the scenario is like this. Let's say you get a balloon, you blow in air. So as you blow in air into that balloon, it begins to expand. So that expansion of the balloon, when you release and stop blowing air, it will recoil and return back to its normal shape, and size. So that one actually gives us a good example of good elasticity of blood vessels, where the balloon had expanded when blowing it, and when you release air, then it recoils back to its normal size. And that expansion again, let's talk about the expansion. As you are blowing in air, that balloon begins to expand. So when it's expanding, it's trying to reduce pressure. As more air goes in, pressure builds up, so it expands to try and accommodate that pressure. And if you continue blowing it, there comes a time when it reaches a limit where it can no longer stretch. And that's where resistance has to come in. So it will no longer stretch, so it will try to resist that pressure that's still coming in as you continue blowing into the balloon. So now, because this is a fragile thing, when you continue blowing in, it will just pop up. That will just show you like it couldn't accommodate the pressure anymore. And even such a thing in a case of hypertension, it can happen actually, rupturing of blood vessels, because the blood vessels can no longer accommodate this pressure now. So it's good to think in those lines. You have to be able to connect ideas. I always encourage connecting ideas. So now let's say you were blowing air into a thing where when it reaches its maximum stretch and it begins to resist, there is no way that it can pop. Actually, it's strong. It will maintain its structure. What will happen is that pressure now will start trying to find ways of decreasing itself, and it will actually backfire. So it will become difficult for you to blow in more air, because pressure now begins to move. I mean, the air begins to move down the pressure gradient. So inside that balloon, there is more pressure. So when you try to blow in your mouth, there is less pressure. Hence, air starts forcing itself back into your mouth. Your cheeks end up just blowing. As you are trying to blow in air, your cheeks are also blowing. And there will come a point where you can no longer even blow in air. You see that one. So now let's say this is the heart. In this manner, I would say, when you talk of systemic vascular resistance, when you reach that point where you can no longer blow in air, and the air is more like trying to find a way in your mouth to relieve that pressure, that's where now you can think of vascular resistance, where this vessel is, maybe let's just constricted, and it can no longer, dilate to create more room. Hence, pressure will build up. And the other thing that you can picture from this scenario is that blowing of your cheeks, as you continue blowing in, and then pressure begins to move, the air begins to move down the concentration gradient, and your cheeks begin to blow. That one can give you a good picture on how the heart tends to overwork itself to try and pump out blood. Because there is more pressure within the arterioles. So when it tries to contract to eject blood out of the ventricle, it's pumping it against a higher pressure gradient. So it actually becomes harder for the heart to pump out blood, and it actually has to overwork itself to continue pumping blood out. So I hope you learned something from that picture I was trying to create. Okay. So now we can move on to the mechanisms that regulate blood pressure. So these mechanisms that regulate blood pressure, the main mechanisms are actually two. It's the Barrow reflex. This Barrow reflex is also refers to as the autonomous nervous system control and or mechanism. And the second one is the renin angiotensin aldosterone system, or the LAS system, which also regulates blood pressure. But we also have other hormones or factors that can also, influence help regulate blood pressure, such as ADH or antidiuretic hormone produced by the posterior pituitary gland, and we also have ANP, which is atrionatriuretic peptide, which is also a hormone produced by the atria of the heart due to increased stretch as a result of increased venous return. Yeah, so now, before I talk more about these mechanisms that regulate blood pressure, one thing that I would like to talk about is that these mechanisms can also be grouped into short-term mechanisms and long-term mechanisms. Yeah, of which short-term mechanism refers to those mechanisms that will come in action and try and regulate blood pressure immediately and bring it back to homeostatic levels. Yeah, and long-term mechanisms are those mechanisms that will come in later on to control blood pressure on a long-term basis. Yeah, so under this short-term mechanism, that's where we have the baroreflex or the autonomous nervous system control of blood pressure. And we even have another way in which this control can happen, which is chemoreceptors. I'll briefly mention, but let's mainly focus on baroreflexes. So these baroreflexes or baroreceptor reflexes, it's actually controlled by the autonomous nervous system, like I've already mentioned. And how this is done is simply by increasing or decreasing sympathetic output or parasympathetic output. So let's say in a case where sympathetic output is increased, parasympathetic output is decreased, and the opposite is also true. Yeah, so uh, before I go into details to talk about these mechanisms, mainly the baroreflex, because it deals with the autonomous nervous system, there's one thing that I want us to understand. Well, okay, so in the brain, in the brainstem, we have two main areas: the pons and the medulla. So the medulla in the brainstem contains centers, and the two main centers that we're going to talk about in reference to BP control are the cardioregulatory centers as well as the vasomotor centers. So these cardioregulatory centers it's actually the center now which regulates heart rate. Yeah, it's the one that can send signals to the SA node to actually increase on the the heart rate or decrease the heart rate. Yeah, that's what that's its main function, to influence the heart rate and by sending signals to the SA node. So the vasomotor center, this one mainly works by either causing vasodilatation or vasoconstriction. Yeah, so it will send vasoconstrictor impulses, then vasoconstriction occurs, or vasodilatation, depending on the situation, of which we'll talk about briefly. Yeah, so everything that we're going to talk about here, we're going to rely mainly on the vasomotor center and the cardioregulatory centers, which are found in the medulla, of which signals will be sent, impulses will be sent, and they will reach the medulla through the tractus solitarius, which is actually a sensory nucleus that receives the sensory impulses and later on sends a feedback signal on how to respond to that situation. Yeah, based on the situation, and if the response that helps to maintain homeostasis it's either parasympathetic activities being enhanced or sympathetic activities being enhanced. Okay, so now we can talk about baroreflexes. So the baroreflexes or baroreceptor reflexes is this actually works by sending signals to the brain. So main blood vessels such as the carotid and the aortic arc, they have pressure receptors. Yeah, so in the carotid sinuses and the aortic arc, we have pressure receptors. So these pressure receptors, they will detect pressure changes. Yeah, and when there's maybe increase or decrease in pressure, they will send the impulses to the brain in the through the into the medulla through the tractus solitarius, where a feedback will be sent on how to respond to maintain blood pressure. Yeah. So let's say blood pressure increases. So when blood pressure increases and it passes through the carotid sinuses and the aortic arc, what will happen in this scenario is that there will be increased amount of impulses being generated and sent to the medulla. Yeah, specifically to the cardioregulatory and the vasomotor centers. So these impulses will actually enhance or rather stimulate the sympathetic output. Yeah. So they will, since we are talking about a scenario where blood pressure increases, so what will happen actually is the opposite of what I've just said. So there will be a decrease in sympathetic output and an increase in the parasympathetic output. So what will happen is this: when the carotid sinuses detects increased pressure changes through the glossopharyngeal nerves. The impulse goes to the medulla, and in the aortic arc through the vagus nerve goes to the medulla. In the medulla, there will be suppression of sympathetic, output, and there will be increase in the parasympathetic output. And this increase in parasympathetic output, what it will cause, that it will cause decrease in heart rate and a decrease in contractility. When heart rate decreases, the stroke volume decreases, thereby decreasing cardiac output. Then later on, what also happens is that there will be inhibition of vasoconstrictor impulses, thereby promoting vasodilatation. So there will be decreased heart rate, decreased contractility, vasodilatation, thereby dropping blood pressure. Okay, so in the case of low blood pressure, the opposite is true. Sympathetic output increases, parasympathetic output decreases. And this will lead to increased heart rate, increased contractility, and vasoconstriction, thereby increasing blood pressure. So remember, the vasoconstriction is coming in due to stimulation of the vasomotor centers, where the vasoconstrictor impulses will increase to cause vasoconstriction. The increased heart rate in this case of low blood pressure, it's coming in because of stimulation of the cardioregulatory centers, where the cardio acceleratory impulse stimulation will enhance to increase heart rate and contractility. Yeah, so that's it about baroreflexes. Then the other thing to understand here is that not only baroreflexes but even chemoreceptors, yeah, like in the cases of, let's say, decreased oxygen and decreased pH, yeah, with increased partial pressure of carbon dioxide, what would simply happen in this state is that there will be stimulation of the vasomotor centers. So this stimulation will cause vasoconstriction. This vasoconstriction is trying to enhance blood flow and maintain tissue perfusion, because we are now in a state of decreased oxygenation. Yeah, and the other thing that would actually come in this state is that there will be also enhanced sympathetic output and stimulation of the cardioregulatory centers, where there will be increased heart rate to pump blood fast to maintain perfusion, as well as oxygenation because of the decreased oxygen state, as well as the respiratory centers in this state, they will come in because of the same decreased pH, increased partial pressure of carbon dioxide, and decreased partial pressure of oxygen. So the respiratory centers also be activated to enhance on that respiratory rate. Yeah, so there'll be some sort of hyperventilation to maintain that ventilation excretion, or rather exhalation of carbon dioxide and inhalation of oxygen, again to maintain oxygenation as well as perfusion. So chemoreceptor mechanisms can also in a way end up affecting blood pressure in terms of short-term regulation. Okay, so now we come into the long-term mechanism, and the main long-term mechanism talked about is the renin-angiotensin-aldosterone system. So under the renin-angiotensin-aldosterone system, here basically what happens is that when blood pressure drops, yeah, and blood is flowing through the kidneys, yeah. The decreased blood flow within the kidneys, as well as the resultant decrease in glomerular filtration rate, will be detected by one, the macular denser cells, and two, the juxtaglomerular cells. Yeah. So when the macular denser cells detect this decrease in pressure and decrease in glomerular filtration, what will happen is that they will enhance the reabsorption of sodium, which will also cause water molecules to follow by osmosis, thereby increasing blood volume, preload, maintaining blood pressure, as cardiac output also ends up increasing as the process, in the process, I mean. Yeah. So yeah, basically that's what will happen due to activation of the macular denser cells. Yeah, and the other thing that will happen is that in the juxtaglomerular cells, these cells will produce an enzyme known as renin. So what renin will do is that it will metabolize angiotensinogen, which is an inactive protein, into angiotensin 1, which is active. And this angiotensin 1 will flow within the system and reaches the lung capillaries, where there is the angiotensin converting enzyme, and it will be converted into angiotensin 2. So now this angiotensin 2, it's actually a potent vasoconstrictor. So it will cause vasoconstriction, as well as increase preload, and later on increase blood pressure. Yeah. But the other thing that angiotensin 2 does, apart from vasoconstriction, is that it stimulates the adrenal cortex to produce a steroid hormone known as aldosterone. So this aldosterone will be produced, and what aldosterone does is that it stimulates the reabsorption of sodium and water molecules by osmosis, thereby excreting potassium in exchange. Yeah. So it will also help to maintain blood volume, increasing preload, and later on stroke volume is boosted, then cardiac output increases, then you have an increase in blood pressure. Yeah. So when you think of the long-term mechanism that helps to control blood pressure, think of blood volume, because basically that's where the main control takes place. And when we talk about antihypertensives, in terms of maybe the RAS system, so we even have antihypertensives that can affect the RAS system. Let's say we have antihypertensives that can block the conversion of angiotensin 1 to angiotensin 2, which is angiotensin converting enzyme inhibitors like enalapril. Yeah, we'll also talk about angiotensin receptor blockers, angiotensin 2 receptor blockers, which will block the receptors on which this angiotensin 2 acts upon, in order to induce those effects of vasoconstriction and enhanced aldosterone production. Yeah, which ends up reversing the process and lowering blood pressure. So we'll talk more about that one. We even have one which actually blocks aldosterone, which is known as an aldosterone antagonist. So it blocks aldosterone, thereby promoting sodium excretion, and water follows by osmosis, increasing urine osmolarity, and sparing potassium, thereby lowering blood pressure. But we'll talk more about that when we talk about antihypertensives. At the moment, what I just want you to understand is how these mechanisms help to regulate blood pressure. So baroreflexes would detect pressure changes within the carotid sinuses, where they're located, as well as the aortic arc. When pressure changes, the number of impulses being generated also changes. When pressure increases, more impulses are generated. Pressure drops, lesser impulses are generated. And these are interpreted, and the end result is either increasing sympathetic output and decrease parasympathetic output, or increase parasympathetic output and decrease sympathetic output. And when parasympathetic output is increased, heart rate decreases, contractility decreases, vasodilatation occurs. When sympathetic output increases, heart rate increases, contractility increases, and vasoconstriction occurs. On the renin-angiotensin-aldosterone system, there are system. This one actually just works on angiotensinogen, this protein, by converting it into angiotensin 1, which is later on converted into angiotensin 2 by angiotensin converting enzyme inhibitor found in the capillaries that are located within the lungs. And when it's converted into angiotensin 2, the angiotensin 2 now is a vasoconstrictor, which causes vasoconstriction, increases resistance, thereby boosting blood pressure. Then later on, it also stimulates the production of aldosterone. And this aldosterone, what it does is that it enhances the absorption of sodium in the distal convoluted tubules, where enhanced reabsorption of sodium will attract water molecules by osmosis, increasing blood volume, increasing venous return, ventricular filling, and stroke volume also increases. Cardiac output is boosted, blood pressure also increases. So that's the picture that I want you to have, and you will pardon me for being fast. I was just trying to do a quick recap so that you can clearly understand what I'm trying to say. So these other mechanisms that we have that also regulate blood pressure, we just have, ADH. So what ADH does, these ones, they work in specific situations. So like for ADH comes in a state of reduced blood pressure. So when there's a drop in blood pressure, the posterior pituitary gland will produce antidiuretic hormone. This antidiuretic hormone, what it does is that it just, prevents diuresis. Yeah, one that's called antidiuretic. So it just prevents diuresis, thereby retaining more water to maintain blood volume. Yeah, that's basically what happens there. Then the arterionatriuretic peptide, actually this one, it's a hormone that is produced as a result of increased blood volume, because increased blood volume promotes that the increase in venous return, and this increased venous return will cause increased arterial stretching, which will actually stimulate the production of this same hormone, which helps to reduce blood volume by enhancing sodium excretion, thereby excreting water by osmosis in order to drop the blood volume. So basically that's what happens. But always remember, mechanisms that regulate blood pressure can be grouped into short-term mechanisms and long-term mechanisms. Short-term mechanisms are usually autonomous nervous regulated mechanisms, and they are immediate within a short period of time. They will regulate BP by generating nerve impulses that will travel to and from the brain through vagus nerve, as well as the glossopharyngeal nerve. Then feedback can either come back through the vagus nerve or the spinal cord nerve branches in terms of sympathetic feedback. Yeah, so quite important to understand there. Then basically that's that. Long term, it's the renin angiotensin aldosterone system, the last system. Yeah, and it usually works effectively by dropping the blood volume. Yeah. Okay, so basically that's just that about the mechanisms that regulate blood pressure. Okay, so this, guys, is just something to show you what we've already talked about. So remember, we talked about blood pressure, and I said when you talk of blood pressure, think of cardiac output and peripheral vascular resistance, because these are the two main factors that will determine blood pressure, which is the mean arterial pressure. So we said BP is determined by cardiac output, and cardiac output is determined by two main factors, which is stroke volume and heart rate. And we talked about heart rate, just the number of beats per minute, and the more rapid, the more you frequent that stroke volume being ejected, thereby just increasing the volume within the vasculature and boosting cardiac output at the end of the day. Yeah, and the stroke volume just refers to that volume now per contraction, and when it's increased, actually the pressure increases. And there are factors, we said there are factors that can also affect this same stroke volume. And we talked about preload, we've talked of myocardial contraction or contractility, and the afterload. And remember, I said preload, when you hear of things like ventricular feeding and diastolic volume and preload, they're usually related because they're just simply referring to the amount of stretch of this ventricle due to that ventricular feeding process as a result of the venous return. So now, always be analytical, like in the sense that where venous return is decreased, you don't expect to have an increased preload, because where do you get that increased amount of stretch when you have less venous return, you see? And where do you get that proper ventricular feeding that will give you that increased stroke volume, or the volume that will be pumped out during systole? So connect ideas like that. Afterload, we talked about the pressure that the heart has to overcome to actually pump blood out. And we said if the pressure is high, the heart will be overworked for it to pump that blood out against a higher pressure gradient. So that can affect the stroke volume at the end of the day. Contractility, we just talked about the force at which it gets to eject. And remember, I mentioned the Frank-Starling's mechanism, where the amount of stretch determines the force of contraction. And I gave an example of a spring, where I said the way a spring gets to recoil, the force at which it recoils is somehow determined by the amount of force you applied to compress that spring. So it's the same thing with Starling's mechanisms: increased stretch due to increased ventricular feeding, increased amount of the strength of contraction. So we've also talked about peripheral resistance, and I told you that when you talk of peripheral resistance, don't stretch your mind much. Think of things like vasoconstriction, vasodilatation. And when vasoconstriction is needed and it's not taking place, that can cause blood pressure to increase. And when vasodilatation is needed, and when vasoconstriction is needed and it does not take place, what would happen is that pressure drops. And when vasodilatation is needed and it's not taking place, pressure increases. So that's what resistance plays with. So blood volume increases, you expect the lumen to increase, but the lumen volume remains the same. There's that resistance. So what happens to blood pressure? It increases. And you also talk about vascular structure, which also can also combine elasticity. In this manner, they are talking about one, the compliance, the dilatation and the constriction, which is vascular tone. You see, is it dilating? Are they dilating or constricting when necessary? And the vascular structure, they're also talking about in this manner the elasticity. No wonder you're having here remodeling and rarefaction. You see, because elasticity comes in here. Are these blood vessels able to return to their normal shape when necessary, not when they remains constricted? Do they remodel? You see, because that actually can affect blood pressure. Let's say they constrict and do not dilate, and then blood volume increases. What happens to the resistance? Resistance increases. Then what happens to the blood pressure? The blood pressure also increases, thereby leading to high blood pressure. So always connect ideas like that. So here we have effects of baroreceptor, the effects of baroreceptors. This is actually giving us that scenario which we've already talked about on what happens during short-term mechanisms of baro reflexes. So let's say there's increased blood pressure. So when blood pressure is increased, the baroreceptors enter. So the baroreceptors that enter the medulla will send an impulse rapidly to the tractus solitarius within the medulla. And later on, what happens is that there will be enhanced parasympathetic output via the vagus nerve, which would lead to secondary signals inhibit. So the secondary signals will inhibit the vasoconstrictor center of the medulla and excite the vagal parasympathetic center, which is what I'm trying to explain. So increased impulses go to the brain, signifying increased pressure and increased amount of stretch. Then the tractus solitarius interprets that sensory impulse and sends feedback, and there is enhanced parasympathetic activity and decreased sympathetic activity. Then later on, what happens? You have vasoconstrictor signals being inhibited, thereby promoting vasodilatation of the veins and arterioles, and it decreased heart rate as well as strength of heart contraction due to that same parasympathetic effect where it decreases heart rate and contraction. Yeah, and the end result will be, a decrease in that blood pressure. Yeah. So it says, therefore, excitation of baroreceptors by high pressure in the arteries reflexes causes arterial pressure to decrease, as decrease in peripheral resistance and cardiac output. Yeah, so basically that's that. So here we have, another graph that's just talking about what happens during the short-term mechanisms when blood pressure falls. And actually, this one usually happens when you've been seated for a long time, then you just stand. You just stand abruptly because more blood will just actually pour to your legs, which to your legs, because the veins have dilated, created more room as you were seated. Yeah, due to the disturbance in the proper flow. Then suddenly there's pressure drop, and others they tend to feel dizzy. So within that short period you feel dizzy. What simply happens there is that lesser impulses are generated within the carotid sinuses and the aortic arc, and quickly there's enhanced sympathetic output. So baroreceptor inhibited, yeah, so there will be decreased impulses to the brain, like I'm saying. So lesser impulses will be sent to the brain because pressure has dropped. Then what happens? There's decreased parasympathetic activity, and the sympathetic activity will be increased. Then what will be the end result? So the end result will be the heart rate will increase and the contractility will also increase. What will happen when there's a stimulation of the vasomotor center? There will be actually increased vasoconstriction to maintain that resistance. Yeah, and as a result of this same sympathetic activity, the catecholamines are also produced, which also enhances the heart rate, contractility, and vasoconstriction. Then what do you have at the end of the day is increased blood pressure. So that's it about this diagram. All right, guys, thank you for your time, and I hope this tutorial helps. I know it's been a long one, but I try by all means to bring out the best information that can be helping. In case you have any questions or any queries, just drop the question in the comment section, and we'll be glad to help in no time. Stay blessed.